I'm Davin Evanson. I'm a second-year medical student at Drexel University, and I'll be presenting on a subpericardial hematoma following coronary angiography. This was a rare case that demonstrated an occurrence of a subpericardial hematoma following a percutaneous intervention in an individual presenting with symptoms of a myocardial infarction. The case study, or the summary, was a 76-year-old male who had chest discomfort and shortness of breath and bilateral pitting edema. So pretty classic presentation for a myocardial infarction. Past medical history was significant for a coronary artery bypass grafting, which utilized the saphenous vein graft. And the labs at that visit demonstrated an elevated BMP and troponin levels, so diagnosed with an NSTEMI originally. The patient was taken to the catheterization lab, and there was a 99% stenosis of the vein graft. As the physicians tried to pass the stenosis, they had significant difficulty in doing so. It required multiple predilations and multiple failed attempts to cross the stenosis, but eventually there was successful advancement of the stent. And however, there was a consequent perforation of the vein graft, which we'll review in the imaging here soon. In the cath lab, an echocardiogram demonstrated no pericardial effusion, and repeat injections revealed decrease in flow through the perforation. So the patient was removed from the cath lab and then monitored via imaging. So then a non-contrast computed tomography chest scan was obtained, and a focused contrast was found, which is demonstrated in images 1A through C by the yellow arrow. There's that hyperdense focus there, which was concerning, obviously, due to the non-contrast CT setting. So then a new diagnosis of a subpericardial hematoma due to perforation of the vein graft was made. And then they decided to, for management purposes, to monitor this via repeat CT scans to show if this hematoma was stable or if it was continuing to, the blood was continuing to leak. So in the images, you can see just the red outlines. Those are outlining the subpericardial hematoma in different planes. The A is coronal, B axial, and C sagittal. And originally this mass was about 7 by 3 by 5 centimeters. And then on repeat, which is in 2A and 2B, it had shrunk to 5 by 4 by 2 centimeters. So it had shrunk a little bit, and then a couple months later, there was follow-up CT that showed further shrinking of this. In images 1A especially, just to the left of the furthest left red arrow, kind of covered by it, you can see some fat induration, which is significant for any inflammatory process that is occurring there. The interesting and significant thing with this is that typically coronary artery perforations only occur in about 2.9% of percutaneous intervention procedures, and hematomas only occur about 0.1% of the time. And the gold standard for perforations is balloon tamponade, which was sufficient in this case. However, acute complications can occur, such as shock-based organ failure, cardiac tamponade, MIs, stroke, heart failure, and various bleeding events. The concern in this patient was any delayed complications, and thus the repeat CT scans, which include cardiac tamponade, peripheral vascular injuries, electrical instability, and any acute vessel closures or cardiac arrest, and obviously ultimately death. Fortunately, in our patient's case, the hematoma was self-limiting and stabilized. However, this patient will probably require further follow-up every couple months to make sure that this hematoma is continuing to shrink and is not causing any further issues. The case shows that a CT is a quick, convenient, and precise imaging modality, and a very precise imaging modality for this type of situation. An MRI can be used, but it's usually better to estimate the age of hematoma versus where CT is able to demonstrate the hematoma in multiple different planes. And I have my references listed at the bottom there as well. And that is all I have. Thank you. I'll take any questions if there are any.
I was just curious, and this is purely, I mean, you touched on obviously the pertinent medical history, I'm sure, but was there anything that jumped out about the patient history that other than what was listed on the poster that you thought maybe bore mentioning?
Yeah, the patient, from what I remember from looking at the file, they also had like obviously some hypercholesterol, some family history, a lot of family history of previous MIs, hypercholesterolemia, and I believe I believe their father had passed away from a repeat myocardial infarction too. And so, other than having that coronary artery bypass, they'd had some other significant history that led to that first myocardial infarction, that then obviously probably led to further stenosis of that bypass, the vein bypass.
Thank you.